So welcome again to the third lecture in the Minimed service at Jewish Elder Care. Tonight we have a distinguished panel who we will meet as they get up to speak to us. The topic of tonight's lecture is the ethical dilemmas around hydration for end-of-life treatment. And we're going to start with Susan Cliff, who's a social worker and the professional coordinator of social services. She's been working at the Donald Berman Maimonides Hospital for a very long time and has a great deal of experience in dealing with our elderly population.
Today I'm going to be wearing the hat of a head nurse who unfortunately was unable to be here today. This is Nicole Lavoie. I'm going to be presenting a case that typifies some issues that we struggle with in long-term care. My presentation is going to be a little bit more clinically oriented than I'm accustomed to as I'm presenting from a nursing perspective. Lily, will questions be at the end?
At the end.
Okay, so this is a case of a gentleman, Mr. E, who's 92 years old. Mr. E was admitted to the Donald Berman Maimonides Geriatric Center in September '09. Along with a diagnosis of dementia, he had other medical problems such as coronary artery disease, hypertension, diabetes, atrial fibrillation, bladder cancer, and he had a pacemaker. In spite of his dementia, he was able to converse with people many times quite coherently. He was oriented to person. He was charming, delightful, had a beautiful smile. He was able to walk independently with a walker and would walk all over the unit. Unfortunately, in December 2010, December 29th, he fell, went to the Jewish General Hospital where he was diagnosed with a hip fracture. He underwent surgery, returned to our center on January 10th, 2011. A few hours after his return, he was found to have a severe rectal bleed and was sent back to the Jewish General Hospital, where he remained until March 3rd, 2011. When he came back to Maimonides, we found a marked deterioration in his physical, cognitive, and functional status. He came back from the Jewish with multiple pressure sores. He had bullous pemphigoid, a skin condition, which affected his back. He was very uncomfortable, moaning consistently. As I said, decreased cognitive functioning. He was barely alert and able to answer any questions. Intravenous hydration was started. So again, that's March 3rd. 4 days later, he had a swallowing assessment, a dysphasic assessment, where it was determined that he was unable to swallow. The dietitian discussed with his son the pros and cons of PEG feeding. Now, for those of you who may not be aware, it's tube feeding through the stomach. The intravenous infiltrated at that point. The nurses were unable to reinsert the IV, and so crisis was started. Before I go on, I'm going to turn to Dr. Arkan to explain to you what, in fact, crisis is.
So what is hypodermal crisis? It is the infusion of fluid under the skin and not in the vein, okay? And it's used in palliative care to improve comfort in mild or moderate dehydration. It's a technique to hydrate people that is used when intravenous hydration is not easy to install or use. And it's considered safe and useful. And these are sites when you can put the needles, like here, or on the belly, or in the back, and give as much as 1 or 2 liters of fluids per day in this fashion. And this is an example of when it works really well, like in a cancer patient who has a big swallowing problem, but is lucid, he wants to go on with his life, doesn't want to go back to the hospital. You can do that at home. And so this can be a useful technique in this circumstance.
Okay, so on March 8th, the doctor diagnosed pneumonia. An IV was restarted. He was treated with antibiotics and prescribed morphine for comfort as as he was continuing to moan considerably. His condition continued to deteriorate. Mr. E's son was unable to come to our center, but was continually updated by phone, and team members were calling to express their support to him. March 11th, he was seen by a doctor. The intravenous infiltrated again, could not be reinserted, so crisis was started. On the 15th of March, we were finally able to have a family meeting where his condition and prognosis was discussed with the family. The gentleman's advance directives were revised to include comfort care measures. The crisis was not being well absorbed, and the rate of the crisis was decreased. This was March 15th. 3 days later, the gentleman died. We understand that crisis is indicated as a temporary measure in reversible conditions. And as Nicole Lavoie, who is supposed to be here today, questioned, and certainly this is an issue that many of us deliberate, she said, as a nurse, what I see happening clinically to a terminally ill resident on crisis poses an ethical dilemma. And she questioned, why are we in fact doing this? What she sees is a resident who is dying, whose condition is not reversible, and to have to administer hydration through crisis will not improve the individual's condition. At one point, the body, due to a lack of protein, no longer absorbs fluids and becomes edematous. She sees fluid seeping from the skin and the skin being so edematous that it breaks. This surely causes some discomfort to the resident. So the ethical question is, does crisis prolong life, or does it in fact prolong the dying process?